NAFLD subtypes, non-alcoholic fatty liver disease. We can have non-alcoholic fatty liver, NAF, stable or non-alcoholic steatohepatitis. 65 to 70% of these are stable. 10 to 15% develop cirrhosis, develop liver failure, and then from the cirrhosis have a higher risk for hepatocellular carcinoma. This is the new definitions. Why? Scientific understanding, clinical practice, and cultural norms change. They want to get rid of the word alcoholic. They want to just take it out because they feel that causes a stigma. So MAFLD has changed to MASLD, which is metabolic dysfunction associated static liver disease. Fatty liver to steatic liver disease. No one wants to be called fat. And MASLD, guess what? 30 to 40% of the world's population. Static liver disease is now preferred umbrella term for MAFLD, an alcohol-related liver disease. NASH turns to MASH. NASH is non-alcoholic steatohepatitis to metabolic associated steatohepatitis. NAFLD turns to MASLD. MASLD is metabolic dysfunction associated liver disease. NAFLD is the non-alcoholic fatty liver, so we're taking alcohol out. MAFLD to be retired and jammed into MASLD. Isn't this wonderful what we're doing? So this is the new world order. The new world order. Steatic liver disease. Cryptogenic steatic liver disease. This means we don't know specific etiology of the steatic liver disease. Could be a drug-induced liver injury, alcohol-associated liver disease, and MASLD. So we're having different categories. So we have cryptogenic, meaning we don't know, and then we have specific etiology. We can be drug-induced. A young lady who had statin-induced. We can have alcohol-associated liver disease, and MASLD is metabolic dysfunction-associated static liver disease. Then MASH is going to be metabolic dysfunction associated steatohepatitis, and MET-ALT is metabolic MASLD with increased alcohol intake. Oh my gosh, are you tired of this? I am. It's become too much, and I know they're trying to clean this up, but until we get one clear direction, this is kind of horrible because we're living in both worlds where we still have to have the old definitions because people are going to be using these old definitions and the new definitions. And the new definitions themselves, even they've changed. So it becomes harder to differentiate these diseases. All right, so when do we want to look for NAFLD or MASLD? When to screen? Patients with diabetes mellitus type 2 and they're obese, we could get a FIB-4 score. What is a FIB-4 score? So let's go back to that. Patients with over 70% of patients with diabetes mellitus type 2 have fatty liver disease. Isn't that amazing? So the FAT-FIB score is a scoring system that gives us the risk for low, if it's less than 1.3, low risk for advanced fibrosis. Greater than 2.67, it's a high risk for advanced fibrosis. So the scoring system is pretty easy to do. It's age times ALT divided by platelets times ALT. They have calculators for this and can give you information. FibroScan is a way of not getting a certain type of ultrasound, we'll call it ultrasound, and what that does is gives us information, a scoring system on likelihood for cirrhotic liver disease. ELF test is enhanced liver fibrosis test, is a non-invasive blood test that assesses the risk for progression to cirrhosis in liver-related events, including NAFLD and MASH. A low score less than 0.9, 9.80 has a low risk, greater than 10.5 has a high risk. An enhanced liver fibrosis test and demonstrates sensitivity for detecting. So the sensitivity is pretty good at 90%. Assessing liver fibrosis and MAFLD. Non-invasive strategy you use the vibration-controlled transient elastography. FibroScan measures how fast or slow the deep shear waves conduct to the liver. MR elastography, that would be more expensive. It gives positive, continuous measurement, safe and convenient. Negative can have variable performance. So these have the positives is that it's safe, it's easy to do, it's convenient. The negatives gives variable performance. All right, vibration-controlled transient elastography. You get a FIB score, which is going to be age, ALT, AST, and platelet count. Greater than 2.67, get a high risk. This high risk get elastography. 5 is normal. So this is on the elastography. 5 is normal. 10 to 15 is possible cirrhosis. So basically, the vibration-controlled transient elastography, it measures the shear wave until it induces a shear wave into the liver, and it gives a correlation to liver stiffness. If you have a 15 on this, it's highly likely this is cirrhosis, and then 20 is portal hypertension, likely if platelets less than 150. 25 is portal hypertension, is very likely. Conditions that falsely elevate liver stiffness on these exams: acute hepatitis, cholestasis, increased BMI, venous congestion from right heart failure, portal vein thrombosis. You can really think these are, work through these in your mind why. Focal liver lesion, recent food ingestion, that's why you have to be MPO, and respiration variation. Weight loss and histological improvement. Weight loss greater than 10% has fibrosis regression. Gradual weight reduction. Rapid can actually worsen their liver disease. Rapid loss can worsen your liver disease. Weight loss greater than 7% can get to NASH resolution. Bariatric surgery can be helpful. A percentage of BMI reduction from between 19 to 42%. Steatotic hepatitis improved in these patients by 92%. Fibrosis improved 66%. Complete resolution of NASH in 70%. So weight loss is very important. All right, resmetirom. This is going to be our first FDA approved drug for NASH or MASH. We're including all the definitions in so that way, depending on where you are in your career, we can help recognize what's going on. This is also for moderate to advanced hepatic fibrosis, agonist of the thyroid receptor antagonist, promotes hepatic fat metabolism, and prevents hepatic injury resulting in lipotoxicity. Side effects are nausea and diarrhea. So remember, NASH is non-cirrhotic, non-alcoholic steatohepatitis. MASH is the newer, is going to be the metabolic dysfunction associated steatohepatitis. This showed a reduction of fibrosis, no effect on weight loss, and resolution of NASH MASH about 28% in the risperidone group versus 10%. Fibrosis in 25% versus 14%. What's the drug that's going to be the big game changer? And the studies are just coming out right now is the GLP-1s. It looks like they're going to reduce the weight and reducing the fibrosis. This could be another category for the GLP-1s to be used. Vitamin E in high doses can be used to help. There is a warning for this, is that vitamin E in high doses can also cause problems with our heart. So, and then there's a risk of increased intracranial hemorrhage. So things to think about, but we're starting to get changes because before we had nothing for treatment for these besides weight loss, and weight loss is very hard to do. Other treatments: black coffee, protective effect on MASH, NASH, reduction of inflammation and fibrosis, can have a 40% reduction of hepatocellular carcinoma. 1 to 2 cups had a 20%. 75% had greater than in 5 cups. This is black coffee. Nothing in the coffee, okay? And then did you know that 300 milligrams of caffeine intake can cause insulin resistance? So there's a balance in this, is that having these higher doses of coffee can help us, but we're having high doses of caffeine can also cause insulin resistance. It's all a balance. Without diabetes, the Prevalence trial showed 800 IUs of vitamin E daily avoid in males with family history of prostate cancer. So 800 IUs of vitamin E daily. You want to avoid this in males with prostate cancer. Studies are still pending. Remember, high doses of vitamin E can induce risk of cardiovascular disease. So these aren't perfect treatments. Without diabetes, the lean trial, no vitamin E. With diabetes, in the lean trial, vitamin E, consider pioglitazone, liraglutide. This is going to be our GLP-1s. GLP-1s are going to be the answer. It's really going to come down to the GLP-1s. And the data is coming out. There's new medications coming up too. Statins are safe in chronic liver disease and should not be stopped. Increases in liver enzymes do not always necessitate stopping the statin. Remember, we came up with a very rare case in our initial discussion on this. This is to get your brain thinking. It's very rare. Statins are safe. Stop if AST, ALT are greater than 3 times upper limit of normal, or if evidence of cholestasis is present. All right, so let's talk about hepatic encephalopathy. Basically, we're talking about pneumonia that's normally absorbed up from the gut. And we have increased ammonia levels in patients with hepatic encephalopathy. Now, is it just the ammonia itself? No. There's suspected that there's the glutamate molecule is causing problems. And where else do we see glutamate in issues? Schizophrenia. So ammonia is not a perfect measurement of hepatic encephalopathy. So if you look at the GI literature, it says, if suspect hepatic encephalopathy, check an ammonia level, but clinically is more important than the actual ammonia level, because you can have there's case studies with people with ammonia levels in the 300s that are probably more normal than you and I, because they're not listening to these crazy board lectures, right? They're probably having fun. And there's people who have low ammonia levels that have hepatic encephalopathy. So it's not a perfect test. They recommend doing it once. The test can be altered multiple ways. Say, for example, if the tourniquet is on for an extended period of time, when the phlebotomist is drawing the labs, it can throw off our number. Also, too, if it takes time for them to run the ammonia level, meaning it sits on the lab bench for a period of time, they may run them in batches, they may have to send it out, the ammonia level may be wrong. So what can we see from this is we can have confusion, slurred speech, personality changes, atelectasis, remember those flapping tremors. You can even have coma, and this is what this young lady that we had to intubate from the statin-induced hepatic encephalopathy. In cases where the ammonia levels are very high, these in the 200 and 300s, you can develop cerebral edema, which can be seen on CT. Hepatic encephalopathy causes can be hypovolemia with dehydration, leading to from diarrhea, vomiting, diuretic use, excessive paracentesis. Doing too much paracentesis can cause a hypovolemia, excessive nitrogen load from GI bleeding and constipation, hypokalemia and metabolic disorder, metabolic alkalosis, hypoxemia and hypoglycemia, infections such as pneumonia, UTI, spontaneous bacterial peritonitis, portal systemic shunting cause TIPS. So we'll talk about TIPS and we'll talk about the problems with TIPS. So it's a treatment for hepatic encephalopathy. Well, let's go back there. The treatment for hepatic encephalopathy is lactulose is your first line treatment. It's cheap. It's causing you changes in the gut microbiome. This is where it's so important. We're just learning. We don't know much about this. It decreases the production of ammonia. You can consider adding rifaximin. This is more expensive. This is an antibiotic that just stays within the gut, and this decreases the bacteria that increases the ammonia levels. And if patient has high levels where we're worried about cerebral edema, you would consider reducing the intracranial pressure by IV mannitol or hypertonic saline. Remember, serum ammonia levels correlate poorly with the grade of hepatic encephalopathy. So getting serial levels is not a good thing. It's not recommended by the GI Association. We want to do what is we want to treat and watch the patient clinically with lactose is going to be your first line, rifaximin is second line. Now this patient, remember this lady who came in and she had hyperlipidemia, she was intubated, she's on the ventilator. Now she's noted for low sodium. So in cirrhosis, we have portal hypertension. This is causing splanchnic arterial vasodilation. This is also caused by also things that are affected in cirrhosis, which is going to be increased nitric oxide. We have worsening hyperdynamic circulation. We're going to have decreased systemic vascular resistance because of the increased nitric oxide. So we have reduced effective arterial blood volume. This leads to hypotension. And we have, from this, we activate our neurohormonal symptoms, mechanism, and we activate our renin-angiotensin system. Our sympathetic nervous system activates, and this causes us to have hyponatremia.
Hyponatremia. Look at this. The mortality is high as 50%. It's reported with serum concentrations less than 120 milliequivalents. That's not that bad. I mean, you see that on a weekly, sometimes daily basis. Low sodium can make you seize because your neurons do not depolarize well when the sodium gets low. Now, lots of learners will ask for what are the causes of hyponatremia, and literally it's a million. You can go through laundry lists. Pain can be one. Lack of solute intake, that's a simple one. Tea and toast diet, those are usually to work through. Adrenal insufficiency, that's why you get a random cortisol as part of the workup. Then going through the medication list is so important. Hydrochlorothiazide is a big felon in this race. Also, SSNRIs can also cause. So working through the reasons for hyponatremia sometimes can be lengthy. Sometimes we don't always know. Little pearls. Serum sodium is a marker for tonicity. Our serum osmolars, we talked about the gap, and we'll talk more about the gap. Serum osmolars were normally between, we'll say, 285 to 295. So we'll say between, you can make it easy as 300 sometimes, maybe a little overestimating, or 290. Make it 300 for easy, and 290 is probably more accurate. High serum osmolars draws from the intercellular to extracellular. Pseudohyponatremia is low sodium with normal osmolars. You can have high protein, such as IVIG. Hyperlipidemia can throw this off. High serum proteins. I just want to go back to the hyperlipidemia. Hey, this is a tip. Don't ever send anything that you think has, like you're drawing it out and it has all these fats in it. You can see this thing. Don't ever send that through the tube system. That has to be walked down. Just think about when those, if they're elevated chylomicron, triglycerides, it doesn't matter. It just kind of shakes it up and it gums up the lab equipment basically, and it's impossible to get good numbers. It's even hard to get good numbers when you walk it down, but you have a better chance. Walk that sucker down. Have somebody walk it down. They'll love you. They love to get that exercise. Low sodium with high osmolarity can be glucose. Can cause this. Hyposmolar hyponatremia, ADH dependent. Hypervolemic could be CHF, liver failure, nephrotic syndrome. Euvolemic, SIDH, hypothyroidism, adrenal efficiency, ADH dependent. Primary polydipsia, tea and toast diet, where you're not taking in any solutes. A beer potomania, which is just basically you're drinking liquids. The liquid happens to be beer, and you're not having any solids. You can do the same thing with vodka potomania. You're just not having any solutes in. There's no nutrition in the vodka. Now let's talk more hyponatremia pearls. SIADH secondary medications. Well, what medications? These are common. Just think about this. A lot of your patients have these SSRIs. Everybody's depressed. Everybody's sad. Sulfonylureas, opioids, anti-epileptics. Serum uric acid. This can be taken as a measurement to kind of help to see, is the volume up or down? It's going to be increased in heart failure and volume depletion. SIDH is going to be reduced. Now, What can throw this out? Of course, if the patient has gout, uncontrolled gout, of course. SIDH treatment. Let's talk about ways we can treat this. Mild to moderate, we can do fluid restriction, maybe some salt taps. Loop diuretics can help speed the correction. Loop diuretic can help because you're just taking free water out. Loops to loop of Henle, you're going to be knocking those free water out.